This Week in Virology, the podcast about viruses, the kind that make you sick. From Microbe TV, this is TWiV, This Week in Virology, episode 1001, recorded on April 19th, 2023. I'm Vincent Racaniello, and you're listening to the podcast all about viruses. Joining me today from New York, Daniel Griffin.
Hello, everyone.
So weird to say 1001, Daniel.
It's like Space Odyssey, but it's Viral Odyssey 1001.
Well, when we hit episode 2001, we can do 2001, a Viral Odyssey, right?
Yeah. And I think at that point, right, are we going to be propping you up like, Night at Bernie's or something?
I'll be fine. Right. I'll be fine.
Okay. All right, let's jump right into it because we have a lot to talk about. It's been sort of a little while since I've done my clinical update, or it has been a little while. So there are risks and costs to action, but they are far less than the long-range risks of comfortable inaction. And that's John F. Kennedy. Perhaps people can tell I've been helping out my son with his AP US history. But let's start right off with polio. Vincent, I was listening to TWiV number 2.
Oh, my gosh.
Polio is not dead. It was like, I was reminiscing. I listened to, maybe I was getting ready for the trivia night listening to TWiV 1, 2, 3. But this episode, Polio is not dead. We'll leave a link in. It's only 40 minutes. It's a really great episode. Interesting to hear Vincent's take from about 15 years ago.
Wow. Probably different from my current take,
Yes, but let us start with the MMWR update on vaccine-derived poliovirus outbreaks worldwide, January 2021 through December 2022. So for background, as we've discussed, circulating vaccine-derived poliovirus outbreaks can occur when oral polio virus from the vaccine, so the vaccine oral poliovirus containing one or more Sabin strand serotypes 1, 2, and 3 undergo reversion to neurovirulence. You can jump in and tell us if we're using the right terminology. And then prolonged circulation in under-vaccinated populations. Here in the U.S., we saw not an outbreak, but an individual case where a revertant circulating vaccine-derived poliovirus type 2 infected a non-immune unvaccinated individual, resulting in paralysis. So in this report, we read that during this period of time, 76, and they say CVDPV, so circulating vaccine-derived poliovirus type 2 outbreaks occurred in 42 countries. Since 2020, the number of paralytic cases and new emergencies has declined following the introduction of, as they say, a safer novel type 2 oral poliovirus vaccine for outbreak control. And we've talked a little bit about how this is safer. The number of these circulating vaccine-derived poliovirus and they say here type 1 outbreaks increased during 2021 to 2022 as COVID-19 pandemic-associated global routine immunization coverage declined. So I'm going to engage you, Vincent, here and ask about the path forward. And maybe I'll just stop there and engage you. What are sort of thoughts? Like where do we go from here?
So we have a lot of circulating vaccine-derived type 2, right? It's gone up ever since the type 2 was removed from OPV. So now we just use types 1 and 3. And when there's an outbreak of circulating vaccine-derived type 2, we vaccinate with OPV type 2. So we keep feeding the virus into the environment. Now, recently, NOPV2 has been developed, which has a lower acquisition of neurovirulence, but it's not zero. And the hopes is that will eliminate the circulating vaccine-derived polio 2. We don't know if that's the case or not. WHO is very optimistic, but I'm not sure it's an optimism based on any data. I think as long as they put even NOPV2 into kids, we're going to have circulating NOPV2, and I think that will be really hard to get rid of.
Yeah, I mean, there was a recent NPR piece that I was going to leave a link to as well. The dream of wiping out polio might need a rethink. And I think this piece is worth reading, but let me just hit a few highlights, and I'll read a little bit. I encourage everyone to spend the time, read the whole article. But when the Global Polio Eradication Initiative was launched in 1988, the goal was to extinguish polio by the year 2000. At the time, polio was still paralyzing hundreds of thousands of people a year. Some cases were even fatal. In the first 3 months of this year, there have been 15 cases total in the entire world. This sounds like we're almost there, but then comes the challenge we keep alluding to. Countries, particularly in Africa, were declared polio-free, only to have polio pop up again years, even decades later. We've mentioned last year the United States, which had officially eliminated polio in 1979, had a case of the paralytic disease. And the virus has also been found in sewage samples in London, Finland, and Jerusalem, all places where it supposedly was extinguished decades ago. And then the problem, as we've discussed on a few of our clinical updates, is, as just mentioned, we are now using an oral polio vaccine that in the human gut changes back to a neurovirulent virus and ends up in the community as a danger to those who are not immunized. And the update from this article last year, there were 30 cases of wild polio detected, while there were nearly 800 cases of vaccine-derived polio. Of the 15 cases reported in the first quarter of 2023, right, so the last 3 months, 14 are from the virus that mutated from the oral polio vaccine used in lower income countries. And I did want to edit, I think it's an excellent article, but I did want to edit, and Vince, you could tell me if this is a proper edit. So the last two sentences, they say, but the virus spreading in wastewater can also cause paralytic disease. This is most likely what happened last year in the case of an unvaccinated man in New York being paralyzed by a vaccine-derived strain of the virus. And I do want to point out that wastewater does not end up in the drinking water in the U.S. Someone who is shedding the revertant vaccine-derived virus toilets fails to wash their hands, then maybe shakes your hand, touches something, and virus ends up being transmitted. Wastewater in the U.S. is a monitoring opportunity, not a transmission opportunity.
Absolutely. And I want to just say the idea that in 1979, after that polio was eradicated in the U.S. is not correct, because we never looked in wastewater to see if there were viruses there. All we did was eradicate paralytic disease. And if you want to get rid of the virus, which is the goal of WHO, you have to look, and you can't actually look in every sewer globally. So it's impossible to eradicate a virus with so many asymptomatic infections. And that's something that D.A. Henderson, who architected the smallpox eradication program, always said. It cannot have a lot of asymptomatic infections. So I used to think that it was possible, but now, given the circulating vaccine-derived type 2, I don't think we can eradicate this virus. And this NPR article, by the way, is very good because it has that same idea. We need a rethink.
Yeah. All right. Moving into influenza. The article, Risk of Death in Patients Hospitalized for COVID-19 versus Seasonal Influenza in Fall, Winter 2022-2023 was published. And it's actually gotten a lot of press. It was published in JAMA. In the first year of the COVID-19 pandemic, 2 U.S. studies suggested that people hospitalized for COVID-19 had nearly 5 times the risk of 30-day mortality compared with those hospitalized for seasonal influenza. So these investigators used the electronic health databases of the U.S. Department of Veterans Affairs, the VA. I should mention that was my first paying job as an MD, working for the VA. But between October 1st, 2022 and January 31st, 2023, enrolled all individuals with at least one hospital admission record between 2 days before and 10 days after a positive test for SARS-CoV-2 or influenza and an admission diagnosis for COVID-19 or seasonal influenza. And so, basically they're comparing here flu and COVID-19. I still remember that Roxanne Comsey article, COVID is bad, comparing it to the flu is worse. Well, here they're doing that. The death rate at 30 days in a VA population in fall, winter was 5.97% for COVID-19 and 3.75% for influenza, with an excess death rate of 2.3%. So compare with hospitalization for influenza. Hospitalization for COVID-19 was associated with a higher risk of death, 1.6, so 1.6 times higher. And as they comment here, these findings should be interpreted in the context of a 2 to 3 times greater number of people being hospitalized for COVID-19 versus flu. So we actually end up with about 4 times as many people hospitalized dying from COVID than from the flu. So we're not quite there yet with getting this to the background of the flu. They have a really nice figure where you can actually break down the hazard ratio. And really what I think we've been saying for a while, which is really true, the biggest issue here, the biggest hazard ratio, death rates, percentage of excess deaths is in those over 65, in those unvaccinated. Oh my gosh, there's still some of those around. Those who did not get outpatient COVID-19 antiviral treatment.
So Daniel, is the VA population representative of the general U.S. population?
I think there are quite a number of differences. So I think that's a reasonable comment. I mean, if anything, you're going to be seeing an older age group, right? So I think it's good that they broke it down that way. It's interesting whether or not there are more comorbidities, but... All right, Mpox. Oh my gosh, what are we doing talking about Mpox? Isn't that over? Just want to plug CIDRAP out of University of Minnesota. This is a plug, not an endorsement. They do a great job of keeping on top of things and sending out very accessible newsletters. And recently they had the news brief, recent French Mpox cluster includes fully vaccinated patients. Here they share and explain a recently posted update by the French about an Mpox cluster that occurred in the Centre-Val de Loire region, with 17 cases reported since the first of the year, including 14 since March 1st. 5 of the patients had received 2 of the Mpox vaccine doses. Also, 5 had received 1 smallpox dose during childhood, plus 1 dose in 2022. And they reported that 59% of the infected people had been vaccinated. So we'll put in a link to that. And why am I talking about this? Well, we also have the article, The Lancet Infectious Diseases, 2 individuals with potential monkeypox virus reinfection. Oh my gosh, so you can get reinfected and you can get infected after vaccination. So here we read the description of 2 men that had PCR-confirmed Mpox with typical signs and symptoms. Following resolution, both men had negative PCR tests after a symptom-free interval of 1 and 4 months. One developed proctitis, the other a typical lesion with genital involvement. On further investigation, they tested positive for Mpox virus again. There's a 3rd such possible reinfection reported in the BMJ journal, Sexually Transmitted Infections, of a patient who had completely recovered from a primary Mpox infection 4 months previously, despite receiving a complete 2-dose course of vaccination between the 2 presentations. And
just want to emphasize that
yeah,
it wouldn't be surprising if they got infected. The key here is they developed disease, right? And that's what the first infection should have prevented.
We would hope. This is like we're talking about hybrid here in the one case. So yeah. The last thing for this Mpox section, and don't worry, we'll put a timestamp for when this is over. Some people don't like hearing about Mpox. The MMWR epidemiological and clinical features of Mpox-associated deaths, United States, May 10, 2020 through March 7, 2023. So yes, deaths from Mpox, people may have missed that, but we read that CDC received reports of 52 deaths among persons with confirmed or probable Mpox. 38 deaths were classified as Mpox-associated. 6% were non-Mpox-associated. And some of those interesting causes of death included suicide and drug overdose, and 21% of deaths still being investigated. The authors comment that findings in this report are subject to limitations, and deaths may have actually been undercounted. So I do want to point out that Mpox can be a horrible, painful, disfiguring disease, and it can be deadly. And actually, this is now a report on dozens of deaths. And there's a bunch of interesting things here. But I do want to point this out. I think this is important. Nearly all the decedents with complete data on HIV infection were HIV positive, so 94%. So we're basically talking about individuals here that did not have an intact immune system. Among the 24 decedents with HIV, 100% had CD4 counts less than 200, most of them quite a bit below 200. Among the 2 immunocompromised folks that died who did not have HIV, one was thought to be immunocompromised as a consequence of undiagnosed diabetes. This patient experienced diabetic ketoacidosis at the time of the Mpox diagnosis. And the second decedent was severely immunocompromised from a recent renal transplant complicated by acute rejection. So what will happen with Mpox in the future, we will let you know come summer. All right, norovirus winter vomiting disease. I thought we were almost over this. Things were starting to come down, and now we have a little bit of a climb again. So we'll let you know. But winter's almost over, so people will hopefully stop vomiting soon. Okay, here we are, timestamp 16 minutes in, and we are to COVID. Let me say this right up front. Have a plan to stay safe, keep from getting sick, and a plan for what to do if you get an infection. And our government has a new plan, Project Next Generation or Next Gen. So we hear that the Biden administration has announced a $5 billion program to accelerate the development of next-generation COVID-19 vaccines and treatments. And I quote, like Operation Warp Speed, which developed and distributed vaccines in the early days of the pandemic, Project Next Gen will cut across government agencies and involve public-private collaborations. We hear that this plan will develop a roadmap to, and I have some criticisms, develop a nasal vaccine to prevent infection as well as severe diseases, develop longer-lasting vaccines and create broader vaccines that protect against all variants and several coronaviruses, and funding to develop more durable monoclonal antibodies resistant to new variants. And I'll leave in an article to a USA News article by Karen Weintraub. But Vincent, I thought you might have some comments here.
Boy, aren't they going to go crazy over this $5 billion? Whether or not it's going to work or not, the scientists want the money. First of all, we're not going to develop a vaccine to prevent infection. It doesn't work that way. The immune system doesn't come up quickly enough to prevent infection once those antibodies have contracted. So it's a waste of money. Preventing severe disease, the vaccines already do that, don't they, Daniel?
They do. And I think that that's something that is, well, I don't think it's lost on our listeners. I enjoyed the TWiV 1000 discussions with our audience attendees. People get it. Our listeners get it. The vaccines are durable when it comes to protecting against severe disease, that 90% reduction. But protection against infection is transient, 3 to 4 months, that special superpower. Has anyone heard of flu mist? That's that nasal spray for flu. I pretty much think that changed the world. Now, I say that, and I'm worried that we're wasting money. And the other is I worry about the opportunity cost. Are we spending money on a flying car instead of spending money on things that are realistic and viable?
That's a good point. Yeah, that's a really good point. I mean, this develop longer lasting vaccines. Well, we don't even know how long these last. It's very hard to do that. And broader vaccines, that could be a good project where people are already working on that. Yeah. And durable monoclonals resistant to new variants could be done. They have to be not directed at the ACE2 interface, but it could be done. I think those are reasonable. But it's not like people aren't doing these, right? People are doing this. But I do agree with you 100%. It's going to be a waste of money to try some of these other things that we've mentioned.
Yeah. But they've talked to some very intelligent people who are not infectious disease or virology experts or even epidemiologists, but they are very competent. Okay, right up front is a mention of the end of the public health emergency. What does that exactly mean? I mean, one question people have is about telehealth. I mean, during the public health emergency, providers were able to reach out across state lines. I know the Office of Civil Rights is providing a 90-day transition period. And this is going to actually be in effect beginning May 12th and will expire 11:59 p.m. on August 9th. So we'll see what we can do there, because I think telehealth access has really been tremendous. Well, it's been tremendous for some people. It also has been abused by some others. So that will need to be properly addressed. But other news on Tuesday, April 18th, FDA authorizes changes to simplify use of bivalent mRNA COVID-19 vaccines. I think I tweeted this out. They have simplified and made it more complicated. So let's go through this. So here, the FDA amended the emergency use authorizations. I thought we just ended our public health emergency of the Moderna and Pfizer-BioNTech COVID-19 bivalent mRNA vaccines, authorizing the current bivalent vaccines, this is that mix of original and Omicron, to be used for all doses administered to individuals 6 months of age and older, including for an additional dose or doses for certain populations. The monovalents, they're gone, no longer authorized for use in the United States. So in a sense, it's simpler. All those mRNA vaccine doses, they're all the same. So number one, what are sort of the things? Number one, previously vaccinated with a monovalent COVID-19 vaccine who have not gotten a dose of the bivalent vaccine, go ahead, get a single dose of the bivalent vaccine that's authorized. Unvaccinated, this is interesting. Unvaccinated individuals can receive a single dose of the bivalent vaccine rather than multiple doses of the original monovalent mRNA vaccines. And the logic here is the idea that they already have pre-existing immunity, so you just, for them, it's a boost. And then this is what people really were watching for, the headline about additional boosters. So that was just sort of making it easy. It's all the same. You get the same shot for everything. Individuals 65 years of age and older who received a single dose of bivalent vaccine may receive one additional dose at least 4 months following their initial bivalent dose, right? So just folks 65 and older, just folks, as we're about to see, certain kinds of immunocompromised who received a bivalent COVID-19 vaccine can get an additional dose here at least 2 months later. And then this is a big comment here by the FDA, and I sort of hit on this a little. Most individuals have already received a single dose of the bivalent vaccine are not currently eligible for another dose. The FDA intends to make decisions about future vaccination after receiving recommendations on the fall strain composition at an FDA advisory committee in June. And to put this together, there was, several articles, but a recent New York Times article by Christina Jewett, and I'm going to quote a couple folks here. Dr. Peter Marks, the FDA vaccine chief, said, the available data continue to demonstrate, as we've discussed, that vaccines prevent the most serious outcomes of COVID-19, which are severe illness, hospitalization, and death. And then the decision to offer the booster to the most vulnerable this spring is sound for two reasons, said Dr. Daniel Griffin, an infectious disease specialist at Columbia University, who y'all may know. One is the traditional reason for vaccines. It protects people from severe disease. But there is what I call the superpower, where for a matter of 3 or 4 months, you get an extra benefit of reducing your risk of even getting infected. And I will say that we should be reassured, as we've discussed, and Dr. Marks and we have pointed out many times, the vaccines are very successful and have durability in this traditional vaccine efficacy of providing protection against disease, including severity of illness, prevention of hospitalization and death. Also long COVID. For higher risk individuals, boosters do boost, and this superpower of protection against infection can, for 3 to 4 months, give one the extra benefit of reducing the risk of even getting infected. If you don't get infected, you don't get disease. Thoughts, Vincent? Are you over 65? Can I ask that? Is that a personal question?
I am. I'm not getting this. I don't think the benefits are there. I have not seen any data that say this is any better than what I've had. I have 3 doses, the original 2, which were too close together, 3 weeks, 4 weeks, whatever. Then I got the 3rd one, which is properly spaced out. And according to the data, that's good enough to get the broadened antibody response. And then I had a natural infection, which in the words of karate and sete, I'm a superpower. And so I'm not getting anything else.
Boosted.
So if I tested positive again, I would take Paxlovid. I am not taking another bivalent vaccine. There's no reason for me to do that. I'm healthy, as you said before. I'm going to last another 10 years at least for TWiV 2000. No more vaccines, at least COVID vaccines for me.
All right, so variants, I'll mention this. The latest SARS-CoV-2 variant in the Omicron XBB Griffin family is Arcturus, XBB.1.16. We actually know Arcturus. We know the star here in the Griffin household as Hokulea, the Hawaiian star of gladness. So they've moved away from these scary names. This is the star the Polynesians used to navigate by, and the name of my last sailboat. Currently XBBB.1.5, the Kraken is dominant, but Hokulea, or Arcturus as it's being called, is picking up. All right, moving into COVID children, other vulnerable populations. What I was thinking about, Vincent, people have that short attention span. If you want, you could break this into like 2 or 3 pieces. And that way you could listen to the whole thing in 2 or 3 parts. All right, COVID, other vulnerable populations. For those of you who are still with us, the article SARS-CoV-2 during Omicron variant predominance among infants born to people with SARS-CoV-2 was published in the journal Pediatrics. During the period before Omicron variant predominance, the incident rate of positive SARS-CoV-2 tests among infants aged 0 to 6 months born to people with SARS-CoV-2 infection during pregnancy was 3.1 per 100 person years. And during the period of Omicron variant predominance, the rate, what is when something goes up 5-fold, 5-dupled? What's the word there?
Quintupled.
Quintupled to 15.3 per 100 person years. So that was a 5-fold increase. Restricted to infants born to pregnant individuals who had SARS-CoV-2 pre-Omicron. The IRR increased to 5.83. So a lot more infected pregnant mother-to-child transmission pre-Omicron, but the proportion of infants infected less than 14 days after delivery with maternal infections less than 14 days before delivery declined from 31.4% pre-Omicron to 0.8% during Omicron predominance, suggesting the increased rate of infection was not due to increased perinatal transmission. And they've got a nice graph where you can look at the incidence there. You really see the Omicron period and the huge spike for the kids once we get into the early period of the Omicron. Also, the article Severe Maternal Morbidity and Mortality of Pregnant Patients with COVID-19 Infection During the Early Pandemic Period in the U.S. was published in JAMA Network Open. And as we've been pointing out, pregnancy is a high-risk condition. Here we see that pregnant patients with COVID-19 infection at delivery were more likely to develop severe maternal morbidity compared with those without, adjusted odds ratio of 2.6. And what are these bad outcomes? More than twice as likely to end up with a tracheostomy, that's a hole in a tube in your throat, respiratory distress syndrome, ending up on a ventilator, developing an acute myocardial infarction, sepsis, shock, cardiac arrest, and coagulopathy. And the mortality risk of pregnant patients with COVID-19 at delivery was 14 times higher compared to those without. Hope our OBGYN colleagues are listening. All right, and the traditional you test positive period, pre-exposure transmission testing. There were some interesting comments on social media. I don't know if you saw any of these, Vincent, about our recent TWiV 1000 and the mask wearing or not wearing by some folks there. And I think it's really interesting, and I don't spend too much time on this, but we've talked about this before, about the fact that we're in a different situation now. It was actually this week that Optum, actually the care delivery organization I work for, has moved to a mask optional. Use your judgment when wearing the mask. So later episodes, maybe we'll have a little bit more of a discussion. But I am curious about people's take on the ethics here from the article, Sickness Presenteeism in Healthcare Workers During the Coronavirus Disease 2019 COVID-19 Pandemic, an observational cohort study published in Infection Control and Hospital Epidemiology. In this observational cohort study that included all healthcare workers at the Veterans Affairs, I feel like we're beating up on the VA folks, Boston healthcare system, who tested positive for SARS-CoV-2 infection by PCR between December 1st, 2020 and September 30th, 2021. They report about 50% went to work with symptomatic COVID-19. And then they go ahead and suggest this may contribute to the nosocomial transmission of SARS-CoV-2 to this high-risk population, and following this reasoning to the death of a portion of those veterans. So I know how I feel about the ethics here, but I will leave judgment up to our listeners. The MMWR ventilation improvements among K-12 public school district United States, December 2022 is worth a read. Here we hear to reduce school transmission of SARS-CoV-2, K through 12 public school districts implemented ventilation improvements, replacing or upgrading ventilation systems, installing filtration systems, installing ultraviolet germicidal irradiation devices, or improving airflow. Federal funding remains available for ventilation upgrades, but none of the ventilation strategies examined were reported by the majority of school districts. So implementation of ventilation improvements vary by school district, U.S. Census Bureau, region, geographic locale, and poverty level. High poverty school districts reported implementation of the highest percentage of strategies. We also get the article, Risk Factors and Vectors for SARS-CoV-2 Household Transmission, a prospective longitudinal cohort study published in The Lancet Microbe. Now, the authors start by writing in their introduction, despite circumstantial evidence for aerosol and fomite spread of SARS-CoV-2, empirical data linking either pathway with transmission are scarce. Here, they aim to assess whether the presence of SARS-CoV-2 on frequently touched surfaces and residents' hands was a predictor of SARS-CoV-2 household transmission. Just a little bit of circumstantial evidence. In this study, contacts hands, primary cases hands, and frequently touched surface samples from communal areas were tested for SARS-CoV-2 RNA. They reported that SARS-CoV-2 detected on primary cases hands predicted contacts risk of infection with an adjusted relative risk of 1.7, as did SARS-CoV-2 RNA presence on household surfaces, adjusted relative risk of 1.66, and contacts hands, adjusted relative risk of 2.06. I have a few thoughts, but Vincent?
Well, I mean, if you're positive, yeah, you're going to have RNA on your hands. And in your household, you're going to have RNA on the surfaces. It doesn't mean that caused your infection, right?
I also that was kind of a marker for filthy people that don't wash their hands. And
yes.
So,
but of course, and then we don't know if it's infectious, so there's really no relationship with transmissibility.
Yeah, I hope this article does not get much air, but I will just felt like it was important to mention it. All right, COVID active vaccination. We've already talked a little bit here, but we also have the correspondence, SARS-CoV-2 neutralizing antibodies after bivalent versus monovalent booster, published in The Lancet Infectious Diseases. In this study, serum virus neutralizing titers in 41 participants who received 3 monovalent mRNA vaccines, followed by a bivalent booster, a monovalent booster, or a BA.5 post-vaccination infection. They collected serum samples at nearly a month and approximately 3 months following the last vaccine dose or post-vaccination infection, and determined their antibody titers, neutralizing antibody titers, using a pseudo-virus neutralization assay against ancestral D614G and a panel of Omicron subvariants. Patients who received a monovalent booster were older than those who received a bivalent booster. or even those who had a breakthrough infection. They found that consistent with their previous report, there was no significant difference at nearly 1 month after the last booster for the 2 vaccine cohorts. At approximately 3 months after the last booster, there were, again, no statistically significant difference between the 2 groups. The BA.5 post-vaccination infected cohort exhibited significantly higher neutralizing antibodies at 3 months against all tested Omicron subvariants when compared for both monovalent and bivalent booster cohorts. And over the approximately 2-month follow-up period, mean neutralizing antibody titers in both vaccine cohorts decreased approximately twofold or 50% against all tested viruses. But there was no, as they say, discernible waning of antibody responses in the BA.5 breakthrough infection cases over the same period. I've got the figure right up here, some comments. I think these can be optimistic, as we see here. Also, I'll say science-based. Boosters boost, and it looks like we can take comfort in not worrying about needing to get our boosters perfectly matched to the next variant. Vincent, I think you're looking at the figure. Any comments on the data?
Well, so it makes sense that a matched or a closely matched booster will give you good neutralization of those viruses. But as you see, they go down over the 2 months afterwards. And so there's not an advantage to doing that, at least looking at neutralizing antibodies.
All right. And we also have, we're still hitting on these, a letter to the editor. Durability of bivalent boosters against Omicron subvariants was published in the New England Journal of Medicine. And in this report, I think this goes with what we've been saying, we read that effectiveness against severe infection resulting in hospitalization or death, right? Remember, this is above a background, reached a level of 67.4% after 2 weeks, decreased to 47.5% after 4 weeks, 44.3% after 10 weeks, 38.4% after 20 weeks. And these figures are even more beautiful with lots of colors for you there. All right. And I'm going to have some stuff, just a little teaser. I'm going to have some stuff next week about COVID passive vaccination. Is there a replacement on the way for Evusheld? All right, stay tuned, right? That's like a cliffhanger. COVID, early viral upper respiratory non-hypoxic phase. You get infected. What do? We've been saying for a while, number one is Paxlovid. And we have the article, Nirmatrelvir and Risk of Hospital Admission or Death in Adults with COVID-19, emulation of a randomized target trial using electronic health records, published in the BMJ. So using the healthcare database of the U.S. Department of Veterans Affairs. Man, those guys are just giving us data. 256,288 participants with SARS-CoV-2 positive test result and at least one risk factor for developing severe COVID-19 disease between the 3rd of January and 30th of November 2022. Over 31,000 were treated with Nirmatrelvir within 5 days of testing positive. 224,764 received no treatment. And once again, we see that in people with SARS-CoV-2, so folks with COVID-19 who are at risk of developing severe disease compared with no treatment, Nirmatrelvir was associated with a reduced risk of admission to hospital or death at 30 days in people less than 65, older than 65, male, female, black, white, not vaccinated, vaccinated, and even those that received a booster, with those with 1, 2, 3, 4, or greater than 5 risk factors, and in those with a primary SARS-CoV-2 infection, also the folks with reinfection. And the absolute risk reduction varies based upon the pre-treatment risk of progression. Number 2, remdesivir, where you can get it. And people have been asking for a while, a little more info. What about that oral remdesivir? Well, Gilead Sciences unveiled, I like the way they unveiled data from the first human study of its experimental oral COVID-19 antiviral, saying the results in healthy volunteers cleared the way for 2 large phase 3 trials of the drug that have begun enrolling patients. So basically, this is an oral prodrug of remdesivir and will be taken as 1 tablet twice a day for 5 days, theoretically with no drug-drug interactions. All right. And monoclonal therapy. I think it's important that we learn as we go. The article, Evolving Real-World Effectiveness of Monoclonal Antibodies for Treatment of COVID-19, a cohort study, was recently published in Annals of Internal Medicine. So these are the results of A, hypothetical pragmatic randomized trial from observational data comparing monoclonal antibody treated patients with a propensity score matched non-treated control group in a large U.S. healthcare system. They looked at high-risk outpatients eligible for the monoclonals under any EUA. In this study, they reported risk of hospitalization or death at 28 days was 4.6 in treated and 7.6 in non-treated. They went ahead and did some subgroup analysis. Lots of limitations here, but very much in line with what we've seen so far. Molnupiravir after that. And I will not leave out convalescent plasma, an early treatment option for the treatment of immunocompromised COVID-19 patients at high risk for progression of severe disease who have no other treatment options. And we did get a recent ID Society update on convalescent plasma. So I want to clarify or highlight, depending upon perspective. As per the latest update, a new recommendation was developed against the routine use of convalescent plasma among immunocompromised patients with COVID-19. My clarification here, this is about timing. This is about waiting till after you've missed that window. This is patients that are hospitalized with COVID-19. They probably should have said for COVID-19. Folks who have missed that first, week, maybe 4 to 5 days. And so timing really matters. And as I've been saying for a while, let's avoid doing harmful things. Let's stop throwing darts at our patients. I do hope there's a lesson here for everyone about just trying stuff with good intentions. And the article effect of angiotensin-converting enzyme inhibitor and angiotensin receptor blocking initiation on organ support-free days in patients hospitalized with COVID-19, a randomized clinical trial. Published in JAMA, more results from the REM-CAP trial. And in this randomized clinical trial that included 779 patients, initiation of an ACE inhibitor, ARB, did not improve organ support-free days. Among critically ill patients, there was a 95% probability that these treatments actually worsened the outcome, were harmful. All right, the article, Efficacy and Safety of Anakinra plus Standard of Care for Patients with Severe COVID-19, a randomized phase 2-3 clinical trial published in JAMA. And in this randomized clinical trial, Anakinra did not prevent the need for mechanical ventilation or reduce mortality risk compared with standard of care among hospitalized patients with severe COVID-19. And in the discussion, the authors comment that their findings that Anakinra did not prevent the need for mechanical ventilation or reduce mortality risk compared with standard of care agree with those of a Cochrane systematic review, which included results from 4 randomized clinical trials with IL-1 inhibitors that concluded that Anakinra probably resulted in little or no clinical improvement. All right, COVID, early inflammatory, lower respiratory phase. Remember, that's week 2, the cytokine storm. No rebound here. Steroids at the right time in the right patient. Here I want to update everyone on the dosing and patient selection. Currently, the science supports dexamethasone 6 milligrams daily, PO or IV, for about 6 days or less. And we can do harm by overdosing or indiscriminate use outside these parameters. And the recent article published in The Lancet, higher dose corticosteroids in patients admitted to hospital with COVID-19 who are hypoxic but not requiring ventilator support recovery, a randomized controlled open label trial. So people probably remember recovery trial. They found in this study that using higher dose corticosteroids, so dexamethasone 20 milligrams once daily for 4 days, followed by 10 milligrams once daily for 5 days or until discharge if sooner, was not helpful. They observed that 19% of patients in the higher dose versus 12% of patients in the usual care died within 28 days. So a 7% higher mortality when you overdo it with them steroids. So there was also an excess pneumonia reported to be due. So a 60% increase in mortality by going overboard with those steroids. All right. Remember anticoagulation, guidelines from ASH on that, pulmonary support, immunomodulation, remdesivir if it's not too late. And we will move right into and wrap it up with the late phase. Let me start with the article, Risk of Autoimmune Diseases in Patients with COVID-19, a retrospective cohort study published in eClinical Medicine. I recently attended a WHO meeting expanding our understanding of post-COVID-19 condition, the evolving research landscape. It was actually worth the time. A growing amount of research is helping us to better understand the immune dysfunction involving B cells, T cells, vascular system, and other cells. These are the results of a retrospective test-negative cohort study based on the TriNetX US Collaborative Network. And they found that COVID-19 is associated with a different degree of risk for various autoimmune diseases. So you get COVID, and your risk of rheumatoid arthritis afterwards goes up threefold. Ankylosing spondylitis, 3.2. SLE, threefold. Dermatomyositis, twofold. Systemic sclerosis, 2.6. Sjogren's, 2.6. Mixed connective tissue disease, over 3. Behçet's, 2.3. Polymyalgia rheumatica, 2.9, almost threefold. Vasculitis, psoriasis, inflammatory bowel disease, celiac disease, and type 1 diabetes. And I will say sometimes when we've seen these individuals, they have a slightly atypical presentation of some of these diseases. Also, the article Definition of Post-COVID-19 Condition Among Published Research Studies was published in JAMA Network Open as a research letter. And the authors conducted a descriptive study on post-COVID condition definition following the Strobe reporting guideline and performed the literature search using the PRISMA checklist. A total of over 7,000 studies contain information on post-COVID conditions. They reported to have found substantial heterogeneity in defining post-COVID conditions in published studies, with the majority, about 2/3, not complying with definitions from NCE, from CDC, or WHO. So I will say the CDC definition, the term post-COVID conditions, it's an umbrella term for a wide range of physical and mental health conditions experienced by some patients that are present 4 or more weeks after SARS-CoV-2 infection, including by patients who had initial mild or asymptomatic infection. Now, they go on to say, and we're already going to disagree because we think 4 weeks might not be enough. You might want to wait 12. But although standardized case definitions are still being developed, in the broadest sense, post-COVID conditions can be considered a lack of return to a usual state of health following acute COVID-19 illness. Post-COVID conditions might also include development of new or recurrent symptoms or unmasking of a pre-existing condition that occurs after the symptoms of acute COVID-19 have resolved. And I'm going to wrap us up with the last article, Sleep Disturbances, Severity, and Correlates in Post-Acute Sequelae of COVID-19 PASC, published in the Journal of General Internal Medicine. Here we see patients with PASC reevaluated at the Cleveland Clinic Recover Clinic, clever there, between February 2021, April 2022. 60% had sleep disturbances, mostly mild, but 40% had moderate to severe sleep disturbances. So I'll wrap us up here saying no one is safe until everyone is safe. I'd love everyone to pause here, go to parasiteswithoutborders.com, click the donate button. Every small amount helps. We are finishing off. This is the last month of our American Society of Tropical Medicine and Hygiene fundraiser. We'll be doubling those donations up to a potential maximum donation of $30,000 from PWB to the American Society of Tropical Medicine and Hygiene.
It's time for your questions for Daniel. You can send them to daniel@microbe.tv. Daniel, on the live stream we just finished, we were saying how most transmission of SARS-CoV-2 comes from the nasopharynx, very little from the lower tract. And someone said, well, what if a patient is intubated? Does that procedure lead to aerosol generation and transmission? Has that ever been looked at?
So it's a great question, and there's two parts because I've thought a lot about this, having spent way too much time in the ICU. One is most of the time that a person is being intubated, it's going to be in that second week, so it's going to be after day 10. It's going to be after that peak.
Okay.
The other thing is usually you're doing this. You're wearing your N95. You're doing it in a proper room. The intubation, then they're attached to a closed system. So it was really interesting. It was our colleagues in the front lines, the ERs, the urgent cares. I think those were the folks, the primary care doctors, who were seeing patients in the first week when we were seeing the highest risk of contagion.
Okay. Michelle writes, my 92-year-old mom has not had COVID, told me if she gets it, she doesn't even know if she would take Paxlovid. At 92, she has some underlying health conditions, put her at greater risk. I told her she should take Paxlovid. She said several of her friends have taken it and struggled with side effects. She'd rather have an infusion. I have no idea what infusion she's talking about. Could a 92-year-old with COVID present at an ER in New Jersey and receive an infusion of remdesivir? Is there any research which compares the efficacy of Paxlovid with the renal dose of Paxlovid, trying to come up with a plan for mom?
Yeah. So, one is love to talk to your mom or have one of my colleagues talk to your mom. I mean, that's an ideal thing, is have a medical professional spend the time really going through and explaining, risk benefits of different approaches. We still, thank you, hats off to the Catholic health system. Also, Northwell has jumped in on this as well. To provide outpatient access to IV remdesivir, the 3-day treatment, which is an infusion. It's not the monoclonals, which some people are thinking about. As we've talked about, those are kind of off the table right now. New Jersey might be a little bit harder to do. So,
Carol writes, our 38-year-old daughter has type 2 bipolar disorder, ADHD, and PTSD. She has alcohol use disorder, heavy drinker, more than 15 years, developed alcoholic fatty liver disease. Last May, she got COVID, stopped drinking. In November, got COVID again, this time worse, still not bad enough to require medical attention. A couple months later, she moved back home, still couldn't work, persistent cough, fatigue, diarrhea, vomiting. Eventually jaundiced, went to the ER last month. The original prognosis was worrying, but after 2 weeks in the hospital, several days on prednisone, she's shown a lot of improvement. It's my understanding that alcoholic liver disease is on the rise. One article I read gives the impression that the cause is more people were drinking heavily in the first year of the pandemic. I don't doubt that, but I'm curious as to how a mild to moderate, non-hypoxic, but miserable week of COVID affects the liver, the mechanisms involved. She also had Hep C several years ago, but it's been inactive. How common is it for mild COVID infections to significantly increase liver damages in patients with compensated steatosis?
Yeah. No, see, great questions. There's a lot here for our listeners as well. In general, I am not sure how much COVID is playing a part. It sounds like there's plenty of other things here that are hepatotoxic, that are toxic for the liver. For a mild case of COVID, I'm going to sort of put this, someone who either doesn't end up in the hospital or someone who ends up in the hospital but doesn't end up septic. We're not seeing a tremendous amount of liver damage, but we certainly, in the severe cases, particularly in people that end up in the ICU, we can see severe liver issues. We don't think it's actually the virus invading the liver cells. The whole impression is this is mediated either through the sepsis process, the poor perfusion. Sort of shock liver is one of the terms we use to sort of group a whole bunch of complicated inflammatory processes together. But yeah, we think it's more of an inflammatory impact than any kind of direct viral.
All right. And finally, Rhonda writes, Rhonda is a clinical pharmacist at a clinic in Greenville, South Carolina. I'm hopeful you can share your insight with me in guiding my 20-year-old nursing student daughter as she prepares for a 4-week summer midwife internship in Tanzania in June. She's considering taking PrEP prophylactically due to a much higher rate of HIV exposure during this 4-week period and anticipating a high level of exposure to body fluids by nature of this work. Her primary care provider has not even prescribed PrEP, but is in agreement with this preventive action. I believe the travel clinic that my daughter has consulted is also advising this step, although they cannot prescribe it. What's your advice? As a pharmacist, the antiretroviral drugs seem intimidating, but so does HIV. In addition to PrEP, the clinic has recommended atovaquone proguanil for malaria prevention. They also advise DTaP, polio, yellow fever, and typhoid vaccines, as well as receiving all these in one day. CDC has confirmed Marburg in Kagera province. Her internship is in Arusha. No one but me seems to be concerned about this. Would appreciate any guidance you could impart.
Yeah, no, I mean, I think this is the importance of travel medicine as specialists in this field, and I'm one of my areas. So I actually think that this is an important thing to bring up, the issue of pre-exposure prophylaxis. A lot of these countries, 10, 20% of the population is HIV positive, right? So if you're in a situation like this, you're delivering babies, you end up with, blood, other fluids, in your face, in your eyes, in broken, areas of your skin, right? You may end up with a cut, might end up even with a needle stick, right? Hollow bore. These are the things we really worry about. Pre-exposure prophylaxis, it's single pill, Truvada, you take it once a day. It's a very reasonable thing. We're still in the world of telehealth, so folks can still reach out. I'm happy to help with things like that. I think of Marburg as a much, much lower risk. That's something we'll keep an eye on. But yeah, these are the complexities of not only your normal vacation travel health, but your higher risk travel health challenges.
That's TWiV, Weekly Clinical Update with Dr. Daniel Griffin. Thank you, Daniel.
Oh, thank you. And everyone, be safe.